Thank you for this invitation. This is a great conference with great people on board. So let's dive into the topic of Inlet Patch and LPR because this is a difficult group of patients to diagnose and manage. I have nothing to disclose. So, the inlet patch was described more than 200 years ago. Long story short, this is a gastric mucosa localized in upper esophagus. Majority of IPs contain parietal cells, but the rest may not. And in these cases, PPIs are often ineffective in resolving symptoms. There is a quite large discrepancy of IP incidence in the literature. This is because mostly endoscopies can assess its prevalence. Interestingly, it's even high in cadaver studies, so something is not working properly. In other words, this depends on quality of upper endoscopy, technique of examination, and patience. That is why these lesions can be easily missed. There are three hypotheses how inlet patch can be created. The first one, erupted cyst in the esophageal wall, the next one due to reflux, and embryologic nature. But for the sake of this presentation, let's focus on GERD root. Chronic acid, with or without pepsin and bile injury, leads to reflux esophagitis, and reflux may reach the proximal esophagus, resulting in similar reflux changes. Due to chronic esophagitis, the next step are adaptive changes such as metaplasia of the distal esophagus. Chronic injury in the proximal esophagus leads to reactivation of buried columnar cells and forms inlet patch. We can divide inlet patches into 5 categories. Interestingly, patients with IP can be asymptomatic or symptomatic, mainly LPR symptoms or dysphagia. In addition to this, IPs can rarely have malignant transformation, but so far, only 61 cases of adenocarcinomas have been described. And here is an extremely uncommon case of malignancy in the region of inlet patch. 52-year-old man with a history of smoking and alcohol abuse had 3 times in a row ESD because of recurrent carcinoma. Finally, he had subtotal esophagectomy and was healthy. Unfortunately, we don't have any details on reflux or LPR in this case. Inlet patch can be colonized by H. pylori. It seems quite common, as infected 70% of IPs compared to 100% in the stomach. So some say that this could be due to reflux as an upward infection. Although H. pylori is a well-known risk factor for cancer, there is no protocol for routine biopsy from inlet patch. Unfortunately, in majority of cases, patients with IPs are asymptomatic, and that is why they are found incidentally on endoscopy. Only minority of patients complain on LPR symptoms such as globus, sore throat, hoarseness, just to name a few. We know that there are different diagnostic tests or technologies on the market. There is not a single test to prove reflux in patients with inlet patch. So the results should be rather complementary than contradictory. My personal impression is that we don't have enough interaction with ENTs or common discussions such as our meeting, because for now we don't use the same language about the same disease. The range of flexible laryngoscopy is limited by its nature, so ENTs simply cannot find IPs. The flip side is that they see a bunch of abnormalities in the larynx in asymptomatic patients, and we don't understand this phenomena. Plus the fact that inlet patches are often missed on upper endoscopy. So we should try to connect the dots together with laryngologists. John Pandolfino was talking about this algorithm in Dallas, but this scheme is constantly evolving. So at least for now, we don't have a gold standard in detecting LPR in patients with LPR symptoms, and that is why it is so difficult. Quite recently, the Chicago group has also proposed this new algorithm for esophageal motility disorders. As a first stage, they focus on secondary peristalsis measured by flip during endoscopy, and then they offer additional tests such as reflex monitoring or HRM. They're also working on AI, machine learning, and deep learning, so maybe Chicago 5 will cover these novelties in the near future. Upper endoscopy is paramount in diagnosing inlet patch. But the problem is that many IPs are easily missed due to a lack of precise inspection. To make it easier, we can use sedation, distal cap, and narrowband imaging. NBR is a game changer because prospective studies proved its usefulness in about 20%. I always take biopsy because I want to know what I'm dealing with, and then I can reliably plan my strategy. So if you even spot IP and don't biopsy, you don't know exactly what to do. Inlet patches can differ a lot. They can be localized above, below, or at the level of UES. They can be flat or protruding, single or multiple, tiny or large. This is from Mike Smith's group. This is by far the largest population evaluated for the presence of inlet patch and Barrett's esophagus. IP or Barrett's esophagus patients had decreased LES pressure on HRM and increased acid exposure time. So the bottom line is that patients found to have one of these findings should be carefully examined for the other. This is a case of my patient, 28-year-old woman. She had regurgitation for 3 years and was referred to hospital because of food impaction and ongoing upper dysphagia. On first endoscopy, 2 inlet patches were found and she was treated with PPIs, prokinetic and adhesive formula. ENT didn't find any abnormalities. Then she came to me and during endoscopy, her third, I took multiple biopsies with a large forceps because she was constantly complaining on upper dysphagia. Histopathology revealed IM in the inlet patch. The next step was successful APC ablation of IP. While she's waiting for follow-up endoscopy, she still struggles with regurgitation. So possibly the last step would be enteroflex surgery. So let's compare the findings at both sphincters and find similarities. Tiny lesions on both sides. The tongues on the left and on the right. Barrett's esophagus and IP as protruding lesions, both with intestinal metaplasia. I think we still don't have exact terminology of IPs with IM. How should we call them? I'm not gonna talk about Barrett's esophagus here, but I want to show you a couple of slides about so-called normal Z-line, because we already know about a possible link between Barrett's esophagus and IP. Here is the first example of asymptomatic 55-year-old man who was referred only for screening colonoscopy. Upper endoscopy was just proposed him as an additional exam. The 3 mm reddish area turned out to be adenocarcinoma. This case was elegantly presented by Professor Neuhaus from Germany, and it's here on YouTube. So in this case, we should also look for inlet patch. Stu is a great guy, and we were talking about his fantastic lecture in Dallas on normal Z-lines and this 1 cm zone and how this matters. We don't have time for this, but for those of you who were not present at EFS Meeting, I recommend watching his lecture. The conclusion is that 90% of esophageal adenocarcinoma did not have Barrett's esophagus. So how this process happens is a mystery, but here is a possible explanation. Unfortunately, endoscopists cannot reliably distinguish an irregular Z-line versus short Barrett's esophagus versus IM at the G junction. So it brings to 2 conclusions here. First, we don't take enough biopsies and our screening program for Barrett's esophagus is not working very well. And second, how can we assess the real prevalence of inlet patch, knowing that the inspection of Z-lines is rather of low quality? So this conclusion is like a déjà vu, going back to EFS meeting in Vienna. A small minority of asymptomatic patients have cellular progression to Barrett's and cancer. Many millions of such people translate that minute risk into a large absolute number of adenocarcinomas. So this is where we are now. This upcoming meta-analysis is trying to show up this problem. Asymptomatic people can develop Barrett's esophagus in about 5%, and this was only based on populations where examinations of so-called normal Z-lines were excluded. So it's time to update these old definitions and include so-called silent reflux and risk prediction model for asymptomatic patients. Going back to inlet patch. This puzzle seems like an ongoing conundrum. Laryngologists see LPR as main cause of laryngitis, but we don't believe them. We do not understand them. Lots of money spent on LPR diagnosis annually. Inlet patch is underdiagnosed because it's mostly asymptomatic. Silent reflux, which in fact I would call ninja reflux, is present but undercover because, on one hand, it's asymptomatic, so we cannot screen this issue. On the other, it is quietly destructing the Z-line, upper esophagus, larynx, lungs, and so on. So what about this? Does it ring a bell to you? We are dealing with different diseases, but with the same scenario. Ischemic heart disease, diabetes mellitus, and GERD, all of them are chronic and progressive diseases, but with silent cause of illness quite often. Cardiologists and endocrinologists have non-invasive tests like ECG tracing, echo, lab tests, CGMs, etc. So the bottom line is how to spot the problem and act early. Even gynecologists screen asymptomatic patients with brush biopsy. Now, a couple of words on treatment. Ablation of inlet patch looks very promising in patients with LPR symptoms. So far, two technologies became popular, APC and RFA. The newer version, hybrid APC, seems to be better because of low risk of stricture formation. This is a nice example of a 39-year-old man with LPR symptoms and IP. He was treated with APC ablation and his larynx completely recovered and symptoms resolved. Currently, there is no standardized algorithm for the treatment of symptomatic ectopic gastric mucosa. This is only my proposal, but we still don't know how to screen the asymptomatic patients. It's a teamwork, no doubt about it. The whole process should be conducted by different specialists using the same language about the same disease. I recommend watching this neck-to-neck interview because it perfectly illustrates the complete path of this patient. After several attempts, he was diagnosed with LPR and finally got links and could work again as a professional singer. So what's new on the horizon? Our team is currently analyzing the tongue patterns, and all these LPR abnormalities are interesting, and this could lead to the development of novel tests based on AI. What is more, the second edition of Zoom endoscopy can do a hitch, knowing the optimistic data of our previous studies on Z-line magnification in reflux disease. Our team is cooperating with experienced ENTs. They have recently invented a novel biosensor for diagnosing sleep quality. It is well known that there is a link between LPR and obstructive sleep apnea, so stay tuned. To conclude, there is a possible link between inlet patch and LPR because reflux, Barrett's esophagus, LPR may coexist. IP post-ablation may relapse, and ablation of IP heal the laryngitis and stop LPR symptoms. Majority of IPs are asymptomatic. Only minority patients with IP have LPR or typical GERD symptoms. Use narrowband imaging and do biopsy. Check H. pylori infection. If you find Barrett's esophagus, look for inlet patch, and vice versa. I think we need completely novel, non-invasive tests to interact with asymptomatic patients. Last but not least, PPIs are often ineffective in symptomatic IPs. Ablation looks very promising. Thank you.